I will try within these 30 minutes I have to my disposal to give you an overview of the caries prevention performed in Sweden. And as I said before, I give the title Caries Prevention from Birth to Adulthood. Dental caries has existed as long as mankind has walked on Earth. We can from the left figure see that in historical time, prehistorical, the prevalence was very low, but it increased dramatically, as we all know, during somewhere around the middle of the 19th century. Today, it is the most prevalent non-communicable disease, affecting a lot of individuals worldwide. I know that in countries such as India, there may be other general health problems that maybe are more important to address or to deal with. But we all know that dental caries can be a burden to the individual, him or herself, to the dental profession, and as well to the society. Just a few slides trying to illustrate what the caries situation looks like in Sweden at present. These are data from some years back of individuals who go regularly to the dentist. This means that this SKAPA, as it's called organization, they collect automatically data. They retrieve this automatically from journals of the different clinics where these patients get their dental treatment. And we can see that from 2013 to 2022, there has been a change in the caries pattern among the different age group. It goes from 3 up to 11 years. It has been varying a bit, but the picture to the right is a bit worrying. That means that in 9, 10 and 11-year-olds, the caries prevalence expressed as DFT in the primary dentition seems to increase. If we look at some older age cohorts, we have from 20 to 95, and the time frame here is from 2010 to 2018, we can see that this picture is very positive when we look from 20 to 65 years. But then in the elderly, there's an increased prevalence of dental caries, here expressed as decayed and filled surfaces. And of course, it is well known to all of us that the older individuals, they tend to live longer, but they also tend to have a higher number of old teeth remaining up in high age. And as long as you are healthy, as long as you are physically, mentally in good condition, you can also take care of your teeth. But the day things happens, maybe you suffer from dry mouth, you get medication, you maybe start suffering from dementia, it will be very, very hard to take care of your oral situation, and not at least the teeth from a caries perspective. So even in a country like Sweden, there are two challenges for the future, and that is to make sure that all children and adolescents, they get the same support, and that we try to overcome the problems for some of them so that they all have a good oral health, and also to find system strategies on how to support our older population. These are all mean figures that we've shown so far, and I'm just using this figure to present to you the variation that can be seen. To the left, you see the different regions. Sweden is divided into a number of regions, and then you have the three columns: 6-year-olds, 12-year-olds, and 90-year-olds, and it shows the number of caries-free individuals for the first two, and the caries-free approximal areas for the third group. And you can see that there is among the different regions a variation. where, for example, among the 6-year-olds, in one region Skåne, 69.1% of them are caries-free, and it's up to as high as 85.7% in another part of the country. So a lot of effort in this country is on trying to help and make sure that every individual gets the same right to good and optimal oral health. Well, you may think that I'm presenting some negative and disappointing figures, but we would see, if we looked more in detail into these, we would see that in the international perspective, the oral health in Sweden is today very good. As for example, 12-year-olds on average have a DMFT of around 0.7. And Sweden has early adopted to preventive strategies. We have a high support of the individuals, and that has led to an overall good general health. And the factors which I think have influenced the dental status in Sweden is one aspect, that it is a small country. It is easier in a smaller country to set up preventive strategies. Our education from the first year of school up to even university level is free, and that means that anyone who has the qualifications can enter into the dental and dental hygienist programs. Today, the government has decided to support children from the day they're born up to the age of 24 years with free dental care, including orthodontic treatment. We have, due to the knowledge we retrieved early on, today a strategy where we very early implement preventive strategies and then try to support and make sure that these follow the individuals throughout the whole life. We have been able to perform clinical studies in Sweden, which I think has been very helpful in order to understand which strategies that work well in a population. And why I think this is important is, of course, important from an international perspective, but it's also important from a national perspective, because a specific preventive strategy may not work as well in Sweden as well as in another country, and the vice versa, of course. And then we have these registered data. We have collected epidemiological data so we can follow the trends regarding, as we talk now about, the caries status and situation. Just one picture to illustrate the workload of the dentist, or more exactly, what does in the everyday work the dentists spend time on in their everyday dental work. Well, if you look at this in percentage, we can see that the light blue sector, that means that 45% of the time is spent on carrying out different dental examinations, not only including caries, of course, but also others. Preventive strategies takes up quite a large proportion, with 14%. Disease-oriented strategies, 18%, and there lays a lot of the fluoride application, professional tooth cleaning, etc. And the restorative part, that is, we may think it constitutes, or it is a large part of the overall work, but it's actually only 15% today. And treatments like endodontic treatment and prosthodontic treatments, as you can see, they take up a much smaller proportion of the different workloads. So a lot of this work the dentists do today in the clinic is related to dental caries. And very important is, of course, to make a thorough examination and to work with preventive and disease-oriented actions. Well, how should we handle the patient when we come to the clinic, when the patient comes to the clinic? Well, first of all, I think it's very important that the dental personnel, including dentists, dental hygienists, and dental assistants, do have knowledge about disease process and follow the latest knowledge that is spread around the world. And today, of course, the ecological plaque hypothesis is the model that describes the caries development. And this was originally described by March 1999. So it's important for us to have knowledge. As we start talking about the impact of genetics, etc., it's important to understand how this may be influencing the risk for a specific patient. We also need to understand the dental caries, that it is a multifactorial disease. Well, there are some key components. We need a tooth, we need carcinogenic bacteria or a carcinogenic biofilm, and we need, of course, some nutrients for these bacteria, more precisely sugars and starch. But on an individual level, there are a lot of factors that will influence the risk of an individual to develop disease. Some more closely related to the oral cavity, and some more into behavioral aspects of an individual. But just as it's important for us to have knowledge about disease, I believe it's very important for the patient to have knowledge about the disease and disease process. When we start talking about fluoride use, when we start talking about reducing sugar intake, if the patient don't understand in which way this may influence the risk for caries, they may have a difficulty to understand why to use this. And I believe that if they have a better understanding, they will be more motivated to follow our recommendations and instructions. So just as important, once again, for us to have knowledge about the patient. And when we collect the data, we should think about not only the clinical data, do the clinical examination orally and using radiographs. We should assess the anamnestic data very thoroughly. In some cases, it may be needed to add saliva analysis and do more thorough search, or try to get more information about the diary intake, for example, via food diary. The next step is to try to decide upon the risk for disease. And this means the future caries risk for the individual. And there we know that there are a lot of factors that could indicate an increased risk. But by collecting anamnestic data, clinical information, maybe in some cases saliva data, and thorough data assessment, we have a good platform or base in order to assess the future caries risk. And there are computerized programs that can be used for this. The most well-known example, I think, is the so-called Cariogram. But basically, this is a balance between the positive and negative factors, and it's the outcome between these two loaded parts that actually determines the future caries risk. And if we identify an individual with high risk, of course, we need to think a bit differently, increase the preventive actions in compared to someone who has a low risk. It is today considered that the dental profession has focused a bit too much on the operative treatment, that it was in the medical and dental literature is called or described as a downstream approach. We have waited until a patient has developed disease, and then we start doing treatment according in order to help the individual and to restore the tooth, etc. We need to switch to the right side here of this slide. We need to work according to the upstream approach, identify why is an individual at risk, and try to handle these aspects as an early stage as possible, and then we maybe never reach the left part, the downstream approach. This has been described in the literature, medical literature and dental literature, and this picture is taken from the latest issue of the international textbook Dental Caries. That's a chapter written by Viveke Bellum. In Sweden, we very clearly work with different steps of prevention. We have the primary prevention, which is supposed to be for everyone. We have the secondary prevention that is addressed to individuals who have early stages of disease, and then we have the tertiary prevention that of course includes restoration, the operative part, but it also contains further primary and secondary prevention in order to prevent caries from occurring. Looking at this from a life perspective, from the left upper part here with pre-birth, and we follow preschool, school children, adults and elderly, we can see that the strategies may look a bit differently, and different individuals may be involved in the different strategies depending on age. In Sweden, even before birth, the pregnant women get information about the importance of an optimal oral health and how the oral health of the mother may influence the oral health of the child. From birth and onwards, during the preschool time period, the mother and child comes regularly to do or check up doctor or nurses, and in the preschool they are trying to be aware regarding what's served from a dietary perspective, as well as regularly oral hygiene routine. The school is a very important arena for us from an educational perspective, that we have dental personnel who go out to the school and either perform bi-weekly mouth rinses with 0.2% sodium fluoride, or on a more limited number of occasions, but a few times per year, go out and perform application of fluoride varnish in the school. So the school is a very, very important arena in trying to prevent caries to develop in the newly erupted teeth of this age group. The adults, of course, they have to perform the caries preventive strategies mostly on themselves at home, but there are some working environments where it's known to be a higher risk for caries, where there is some extra support with, making fluoride mouth rinse available for them to use throughout the day. Maybe a company will support their staff and personnel to make an extra visit to the dentist for extra checkup per year, etc. And for the elderly, we are trying to set up, although not fully completed, we set up strategies to support elderly who are at nursing homes and houses for elderly, but also to go home to those elderly who live in their own houses. And this is not easy, I would say, I have to admit, but I think we are slowly getting there. Of course, the focus is home care for everyone. I mean, they should try to themselves to take care of their teeth at home, both from a dietary, fluoride use, or a hygiene perspective, and sometimes if they get recommendations regarding antimicrobial treatment, or enhanced saliva for those who have a dry mouth. And in the clinic, we can perform professional tooth cleaning. We can apply fluoride apart from the verbal support and asking people how does it go, how well have you managed to change your dietary habits, etc. The platform for the preventive strategies in Sweden, they consist of the toothbrushing with fluoridated toothpaste twice a day. We don't have any artificial water fluoridation in Sweden, but the fluoride content of drinking water may vary from one part of the country to another, even locally can vary. As I said, we have group strategies, and that includes the school-based programs and strategies for elderly. But of course, the top of the pyramid, that is the recommendations that giving according to the individual caries risk, which has been assessed at the clinic. So, handling of the patient, that is prevention, that is symptomatic treatment, of course, but we also have what is important, the recall follow-up system. That means that most patients, they have signed up at the clinic, the dentists do see them, assess the risk, decide on when they want to see them back in order to evaluate the preventive strategies and see if the risk or the number of lesions has diminished. And depending on risk, the recall interval could vary. And today, very commonly is that you have a recall interval of about 18 months. And I think this is a fantastic way in order to see the patients back and to be able to evaluate and reevaluate the strategies. So we work, as we say, according to a disease individual-oriented strategy. That means education to the patient, focusing particularly on the biofilm removal, the mechanical cleaning, the dietary recommendations and uses of fluoride. And then the regular recall visits to the clinic are important. Of course, like you and elsewhere in the world, we should work according to evidence-based treatment and according to the best available scientific evidence. And as we'll show you in a few minutes, in Sweden we have so-called national guidelines where some experts within the field have gone through the literature and identify the strategies that seems to be the most optimal one in order to handle different conditions. They do not only exist within the field of cardiology or preventive strategies, they have been identified and expressed within all dental fields. But today we need to also listen to the experience of a dentist working maybe with specific kind of group of patients with a special area, and of course not forget the desire of the actual patient. It is important to start preventive action early and establish good dietary fluoride or hygiene habits as soon as possible. This is very important, and that's why we focus so much on even the mothers before birth and the very young children. Caries is, as we all know, a dietary-induced disease, and it's important to both focus on the reduction of intake frequency, but today also it has also been shown important to try to reduce the amount of sugar. There are studies who have shown a strong correlation between the amount of sugar consumed with caries prevalence. So when dealing with dietary aspects and issues, both focus on intake frequency and intake amount. And in order to be able to do this on an individual patient level, we need to ask a number of questions. The most commonly one is, of course, what is consumed? How often is it consumed? But I think that in order to really understand the dietary habits of an individual, be able to give the correct, best possible advice, we need also to ask questions such as when is it consumed? Why is it consumed? How is it consumed? And where? A lot of food and dietary and intake of drinks takes place outside the home, in the society, while sitting on the bus, while driving, while walking around. A lot of fast food is today consumed, even in a country like Sweden. Then we come to recommendation of fluoridated products. And of course, fluoridated toothpaste is the platform, the base for all this. Recommendations to be used from development of the first tooth, around 1000 ppm fluoride, and brush twice daily, but a very, very small amount. We say sometimes that you should recommend the amount that could fit on the child's nail. From 2 to 6 years, we increase the amount to pea size, and from 6 years, the recommendation is to increase the fluoride concentration of the product, take another product, and also go up to 1 to 2 centimeters. Regardless of age, this holds also for the elderly and adults. It is important to have to make it possible for them to follow the instructions on how to perform in the very best way. Not only brush using an optimal toothpaste, but also that the procedure is performed in the most optimal way. So therefore, we have this recommendation, which is so well known over the country, 2 + 2 + 2 + 2. And this means you should brush twice daily. You should each time, now we're talking about from 12 years and onwards, use 2 centimeters of toothpaste. You should brush for 2 minutes and try to avoid eating or drinking for 2 hours afterwards. And of course, 2 + 2 + 2 + 2 may sound very simple, but it's just one way to try to present the message in an easy way and make it easy for the patient to remember. In the preschool and school, supported toothbrushing, as I said before, mouth rinse or fluoride varnish is applied in the school. Just for you not to misunderstand, the picture to the right, that's an old picture from the 1960s. Fluoride varnish is applied twice yearly or 3 times in certain areas in the school. And of course, we cannot get the same optimal handling in order to dry the teeth, etc. But there are studies who support this strategy very strongly and has shown very clearly that it reduces caries prevalence in teenagers. And of course, fluoride varnish as such, to be used also in the clinic, is very much supported and has high evidence in the literature with caries reductions up to 43%, which have been shown. There have been some studies looking at different time intervals on application of the fluoride varnish, and we can see here that it's not a really easy picture to follow. But of course, it seems that the number of applications yearly seem to be important, where the lowest caries prevalence of the proximal areas shown when applied 8 times per year. So the recommendation is from this that if you have a patient in dental chair, patient who comes back regularly, try to take the opportunity as often as possible to put fluoride varnish on the initial lesions. You don't need to do it on all over the mouth, but initial lesions. The national guidelines are shown up to the left. They have shown that based on the literature, the scientific literature, that these 4 strategies are working equivalently well in order to prevent caries from occurring. That means that if you have an adult individual, and in this respect, once again, we talk about adults from 12 years with an increased risk for caries, in addition to daily toothbrushing twice a day with 1500 ppm of fluoride containing toothpaste, they could either add a mouth rinse with 0.2% sodium fluoride daily. They could use fluoride gel in individual gel trays, 5 minutes daily. They could switch toothpaste from the low fluoride to high fluoride toothpaste containing 5000 ppm of fluoride. There are a number of different brands out internationally. Or if they cannot cooperate with home care strategies, which the first three are, then they will come to the clinic and there get fluoride application via fluoride varnish. It's recommended 3 times a year, or 2 or 3 times a year, if you have the high risk, that if you have sound surfaces you want to prevent disease from occurring at. Or the recommendation is 4 times a year at least of an initial lesions in order to stop further progression. And the first natural guidelines were presented in 2011 in Sweden, and they have been very, very highly followed and are very well known by all dental personnel. And it has made us also to get a very identical treatment, I would like to say, for patients, regardless where they seek the dental treatment. Just a final slide. prevention is very, very important. The title was Caries Prevention. And it's very easy to jump into this, when you have a patient, to start focusing on the manifest lesions. And of course, it's important to treat these, to remove the caries tissue, and of course, restore the teeth in order to get an aesthetical and functional good end result. But remember that lesions are just symptoms of the disease itself. It's always important, in parallel to this work, to treat the disease itself. That's the questions: why has disease occurred? How can we stop or prevent disease from occurring in the future? And with this, I think my time is over. And I want to thank you for your attention. For any questions or comments, you're maybe very welcome to contact me on this email address.